So the next presenter is going to be Associate Professor Adam Irwin. Adam is going to be presenting on the DIRECT study. Adam is a paediatric infectious diseases physician. He is a good-looking Englishman, you can see on the screen, but thankfully for us, he's moved to Brisbane, and we've trapped him here for good, I hope. I know we have. If you're not in Brisbane today and you can't see the weather we've got outside, I don't know how I feel for you, because I feel happy for us. Let me put it that way. It's a beautiful day here. So I'll pass over to Adam, who's going to talk to us about the DIRECT study, which is a recently completed study, and I'll leave you to it, Adam.
Thank you, Jason. I'm not quite sure what to say, except to say, in fact, that I'm really disappointed I'm not there. I was hoping to come across to Thurston this afternoon, and particularly, I'm sorry to be missing the discussion of Bling3, not least because I'm supposed to be leading a journal club on the results next week, so I was hoping for some insights. Well, thanks again, Jason, and thanks for this opportunity to talk to you about the DIRECT study, which was a multi-center, non-randomized study of dosing software and pathogen sequencing in critically unwell children and adults on ICU with sepsis. So sepsis is a condition which causes a substantial global burden of disease. The most recent analysis estimates that there were 49 million incident cases of sepsis globally each year. And as a pediatrician, I'd just like to highlight to you that young children are particularly at risk of sepsis. 20 million of those incident cases of sepsis occur in children under 5 each year, and in fact, most in the first few months of life, leading to 3 million deaths in children under 5 each year. Sepsis is a medical emergency. It's a dysregulated host response to infection, leading to life-threatening organ dysfunction and death. It's a leading cause of admission to ICU, and it's a leading cause of death on ICU. And early antibiotics improve outcomes. These data are now quite old from the UK Sepsis Trust, but they summarise the studies which have demonstrated a reduced mortality from sepsis with early antibiotics. They are mostly adult data, and they mostly relate to the severe end of the spectrum, septic shock. But we do now have data to show that this is true also for children. This multi-center study of 54 hospitals in New York State estimated a 40% reduction in mortality associated with the use of a sepsis bundle of care. And intuitively, of course, it's not just early antibiotics, but early effective antibiotics that matter. So in this study of more than 2,000 adults with septic shock, which defined effective antibiotics as an antibiotic with in vitro activity against the causative pathogen, early effective antibiotics reduced mortality. 20% of those, mortality was 20% in those who received antibiotics in the first hour, and approximately 50% overall. And there was a roughly 12% increase in mortality for every hour's delay in effective antibiotics beyond 6 hours. But in order to give effective antibiotics, we'd like to know the causative pathogen and its antimicrobial susceptibility. And conventional methods using culture are slow, and they take days to give us meaningful actionable information. And so we undertook the DIRECT study to attempt to integrate novel methods for pathogen recognition with personalized, optimized antibiotic dosing. It was a prospective, non-randomized study of critically ill children and adults with sepsis in 4 Brisbane ICUs. And in an observational phase 1, we optimized our methods of pathogen sequencing from whole blood and from blood culture broth using Oxford Nanopore MinION, the MinION device. And in this observational phase, we observed antibiotic exposures. And in phase 2, the interventional phase, we implemented personalized dosing using ID-ODS to optimize antibiotic exposures and compare to the pre-intervention phase. And our primary outcome was time to effective antimicrobial therapy, which we defined as the time to achieve a target a trough concentration above the MIC of the causative pathogen. And for those cases in which we didn't have a causative pathogen, we used UCAST breakpoints. So we recruited 156 patients from the 4 ICUs, 108 in phase 1, the observational phase, and 48 in phase 2. This was 94 adults and 62 children. I'll give you a very brief summary of the pathogen detection work. Simply, we struggled to achieve metagenomic sequencing from whole blood, but we focused our attention then on sequencing from positive blood cultures. And in this context, we successfully demonstrated the value of MinION sequencing, achieving concordant pathogen ID in 50 of 52 culture-confirmed cases, and categorical agreement of 89% with conventional antimicrobial susceptibility methods. Now, there are some caveats to that. There were certain organisms that were trickier to perform susceptibility testing in, but broadly speaking, we were optimistic about the impact of nanopore sequencing from positive cultures. And the time to achieve this was approximately 8 to 16 hours from culture positivity. We looked at 175 antibiotic courses in 156 patients. Almost a third of these patients didn't achieve therapeutic antibiotic exposures with empirical dosing in the first 24 hours. And in these patients, we observed a substantial reduction in the time to effective antibiotics, the time to effective antibiotic exposures using ID-ODS. And so what are the implications? Well, we've clearly got some work to do to improve early sepsis recognition. We're looking at host response markers, which are not culture dependent, of course, and we'd like to use clinical variables, routinely collected clinical variables in a more sophisticated way, including with AI. We're continuing to work to accelerate pathogen recognition and AMR prediction using metagenomics and also targeted amplicon panels, and we've got a new prospective diagnostic accuracy study starting soon at Queensland Children's Hospital. And really, we need to move towards trials. What's actually the impact of these diagnostic and therapeutic innovations? And we've been in discussion with other ICU partners around the state about the possibility of testing the impact of these interventions in a cluster randomized trial. And really, we ought to be looking at clinical outcomes like mortality or length of stay. So early recognition and administration of effective antibiotics matters in sepsis, and our novel molecular approaches may have a role in reducing time to pathogen recognition and AMR prediction. And we've demonstrated that dosing software using ID-ODS reduces time to optimal exposure in patients who fail to achieve therapeutic exposures with empirical dosing. But we really need to test the impact of these innovations in a randomized trial. Thank you.
Thanks so much, Adam. That's fantastic.